Good morning. My name's Tom Betts. I'm a consultant oculoplastic surgeon at the University Hospital of Wales in Cardiff. I've been asked to talk about the management of lid lacerations, and I have no financial disclosures. So every eye injury is unique, and an underlying knowledge of the anatomy and principles of reconstruction is key to managing these interesting cases. There's a wide variety of causes, from periocular trauma with common origins such as road traffic accidents and industrial accidents, through to assaults and bites. It's really vital that associated injuries are examined for and repaired prior to the lid, and the aim of lid repair should be performed to maximise the function and cosmesis of the lid. In all cases, a precise history is essential to assess severity. It's very important to establish the timings, as ideally lid lacerations will be repaired within 24 hours to maximise the outcome. The mechanism of the injury, be it with a sharp or a blunt object, will alter the injury pattern and with that associated injuries and how we may be able to repair the lid laceration. We may encounter things like animal or human bites, and therefore a tetanus immunisation history is also necessary. Chemical injuries may accompany a lid laceration, and appropriate irrigation and management of these are necessary prior to any further evaluation of the trauma. I would like to note that you should exercise extreme caution in patients that are young, old, and intoxicated in the context of trauma, where a reliable history may not be forthcoming. When it comes to the examination of our patient, the injuries must be dealt with in order of priority, and therefore the basic airway, breathing and circulation should be performed before focusing on a more focused examination. The observation of the lids and adnexa can be performed before manipulation of the globe, but it's essential to exclude a globe laceration. Following this, visual acuities and visual field should be attempted, and once globe rupture has been excluded, an IOP can be checked and a fundal examination performed. The presence of exophthalmos may indicate retrobulbar foreign body or retrobulbar hemorrhage, and things like subcutaneous emphysema, facial anaesthesia, bone irregularities are all indicative of underlying bony injury. At this point, a focused lid examination can then take place. A penetrating injury is more likely to produce a clear, clean cut that could be easy to close, whereas blunt trauma may cause more maceration and challenges identifying structures. Location along the lid will also dictate potential associated injuries. So specifically, medial injury, as we know, is associated with lacrimal drainage involvement. Tissue loss should be noted, as this may also require some additional skin grafts or flaps to assist the repair. The presence of frank infection may necessitate the commencement of antibiotics and potentially delay in the repair. Any levator damage may also be noted at this point due to ptosis and the ability to elevate the lid. An exposed fat indicates septal rupture and also an increased risk of levator trauma. With regards to investigations in these cases, blood and radiological investigations may be indicated, and that will be dictated by each individual presentation. The cases lid laceration cases, also have a high medical legal risk, and the use of clinical photography and meticulous documentation should be performed. I've tried to avoid lots of photos of trauma and repairs in this presentation and just stuck to solid principles for all to take home. However, to illustrate a common lid laceration presentation, here I had my children demonstrating a very common scenario in Wales where we have two small children playing with a chainsaw. Well, I do hope that this very realistic scenario gets us all prepared for the principles of an eyelid injury repair. So, most eyelid laceration repairs can be performed under local anaesthesia. However, as I've alluded to, children and uncooperative patients can be difficult to get reliable histories and complete examinations, and therefore a general anaesthesia may well be necessary. The local anaesthesia infiltration with local anaesthesia with adrenaline should be performed, as this will aid with the hemostasis, and then a more thorough examination can be performed with a focus on canaliculi, tendons, and the levator. As I've mentioned, the presence of orbital fat indicates septal rupture, and with this there'll be an increased risk of post-septal damage and foreign bodies. The wound will need to be cleaned and debridement potentially, but only of the definitely devascularised tissues, because given the rich periocular blood supply, even ischemic looking tissue will often survive. Antibiotic roles are unclear, but clearly in frank infection would be recommended. The repair of the lid laceration can then be performed in layers, and it should be without undue tension or pulling of the lid margin, which may lead to dehiscence. If the brow is involved, then this should be aligned first and closed, and as mentioned, orbital fat would indicate disruption of the septum, and we should really be exploring this space, but it should be left unsutured to reduce the risk of lag ophthalmos or subsequent compartment syndrome due to retrobulbar hemorrhage. Subcutaneous closure with 5-0 Vicryl is recommended, and 6-0 nylon or Proline would be suitable for the skin. If the lateral canthal tendon is severed, it should be really overcorrected, and as a medial canthal tendon injury often involves the canalicula, this should be intubated first prior to the repair, and we'll review this in more detail in a few slides. So for those cases of lacerations not involving the lid margin, simple closure in layers would be recommended, and as already discussed, subcutaneous closure with 5-0 absorbable Vicryl would be my preference, and then skin closure with 6-0 nylon or Proline. To avoid the risk of post-operative lag ophthalmos and reduce the risk of post-operative hemorrhage, or the consequence of a reduced post-operative hemorrhage, as mentioned, the septum is left unsutured, and for very superficial injuries, glue may be reasonable if it is a clean wound, and steri strips or paper stitches for the most superficial of lid lacerations. Lacerations that involve the grey line, I would tend to repair in the following sequence. So first of all, I'd look to identify the tarsus and key landmarks such as the grey line, meibomian gland orifices, the lash line. we perform a very exact repair to avoid notching and discontinuity of the margin. And so my first primary suture would be 2 millimeters into the wound, away from the wound edge, at a defined structure such as the meibomian gland orifices or the grey line. This suture I would use to get good alignment of the lid, and then loosen and leave long, ready to tie at a later stage. I then keep things simple. There are many different ways of closing eyelid lacerations, but I have stuck to vertical mattress 5/0 vicryl at a 90% depth with knots tied anteriorly, and I found this has been simple and reliable with the lowest risk in my hands of dehiscence. I would then at this point close this and then tie a long lash line suture as well, under which the grey line suture would be tied, and I'd finish with simple skin closure. You have to excuse my limited art skills, but this is essentially a diagram summation of what I've just discussed. So principally a primary grey line or MGO suture to get ideal alignment, subsequently some tarsal plate sutures to give the integrity to the repair, and then to refine the cosmesis, a lash line suture in addition to the grey line suture at the wound edge, and then these are reflected down along the wound and tied into it and incorporated with some simple skin sutures. Just a few brief slides now on more specialist areas, but lacrimal trauma would usually be canalicular and is often associated with the avulsion of medial eyelid from blunt trauma. The mini Monica stent is fantastic for use in simple monocanalicular lacerations, and the biggest challenge in these cases is really finding that cut medial end, which is identified as a white mucosal tissue wall, and you can often, you should be able to identify the lumen. If one's struggling to identify this, one of the little tricks that can be tried would be to inject air under observation of water over the cut end. So air would be injected through the other canaliculus, and then we would see bubbles coming from the cut lumen, and that may be of use. In cases where we've got bicanalicular repair being required, the use of Crawford tubes being tied in the nasal cavity would be recommended. And then finally, thinking about, again, more sort of specialist areas, but of tendons and ptosis and total lid loss. So with regard to the assessment of tendons, one can perform traction tests by pulling onto the tendon under anaesthesia and looking for if there's significant displacement. If we can identify cut tendons, then these can be simply reopposed using 5/0 Proline or similar. But in cases where the proximal end is not identifiable, we may want to place sutures into the periorbiter or more advanced techniques such as transnasal wires or wide plate fixation. With all these techniques, the most important thing I feel is to get a good posterior placement of the fixation to get a good vector for the lid in that medial component. As I've alluded to before, ptosis or fat in the wound would indicate the potential for levator injury, and repair of this should be attempted. However, in cases where there is ptosis post-repair, it may take up 6 to 12 months to see a full resolution, and therefore these cases should be observed for some time afterwards. In cases where there's total lid avulsion, any retrieved tissue should be saved in gentamicin-soaked gauze prior to repair, and alternatively, without presence of tissue to perform a repair, We may look to secondary intention, which it works, as we would know well, in cases of tumour reconstruction, or we may look towards flaps or grafts. So in summary, these are unique injuries. There's often significant associated injury that we must exclude and treat prior to the lid lacerations. I think having a low threshold for general anaesthesia is a sensible position to take, and meticulous closure, potentially by a specialist, will result in the best outcome for the patient as a prime repair to aid good function and optimal cosmesis. I would like to say thank you ever so much for your invitation and for your attention this morning. Have a lovely day.